All right, so these are my disclosures, but my true disclosure is, yes, Steve alluded to, I had been in Pittsburgh. I'm now in Cleveland for a little bit over a year, but I still remain a Pittsburgh Steelers fan, so I'll get that out of the way transparently. I know the Clevelanders in the audience aren't happy, but maybe the last slide will make you a little bit happy. So beyond combination therapy, really we're talking about, can we use therapeutic drug monitoring and potentially get away from combinations? So I'll go some of this just at a high level to take home, to give you some of the take-home points. I think many of you in the room are familiar with this TAXIT study, which was published a few years ago, and this is really using proactive drug monitoring. So for the few in the room that raised your hand and are doing that, probably this is why you're doing it. For those that aren't, let's look at this. So this is really taking all patients and targeting the infliximab level between 3 and 7 as a trough level. Patients were randomized either to following just symptoms and CRP, kind of the good old-fashioned way that you're probably doing this in your practices, versus following the levels and adjusting treatment based on levels, and then looking at clinical remission in 1 year. So what are the results? The blue bars on this slide represent before dose escalation, the red are after dose escalation, and on the left-hand side you can see Crohn's in UC in terms of clinical remission. On the right-hand side you can see the CRP levels. So it's very interesting to see that actually from a Crohn's disease standpoint, there is a difference, but from UC there's not. So TAXIT actually showed a difference in Crohn's, but not in UC. However, even though there was not a difference at 1 year in terms of clinical remission, so for those in the room that say, well, I don't like doing proactive drug testing, TAXIT was a negative study, I think there are a few things to keep in mind. One is, are we using too low of a level? So I think you're hearing us move from 3 to 7, 5 to 10, and with infliximab now for severe disease, we're saying we like the levels more around 10. The other is 1 year not long enough to follow this in terms of patients? The other interesting thing is some of the secondary endpoints, which I would argue are very important in this study. Less patients required rescue therapy, fewer patients had undetectable trough levels, and more patients stayed in a therapeutic range if you adjusted therapy. So it's not to push proactive on anybody, but to show that there are some data. Then Adam Shafit's group actually looked at, interestingly, a study. This was retrospective, and what they basically did was Adam, who's a big proactive therapeutic drug monitoring person, and in his group at BI there are those that are not, and they just essentially compared those two practices. He would adjust the levels based on a 5 to 10 infliximab range. If it was above 10, he would de-escalate. If it was below 5, he would escalate therapy. And interestingly, what he found in the blue is therapeutic concentration monitoring, and then the red are no therapeutic concentration monitoring, and looking at over time the patients that dropped off infliximab. So again, there are a lot of limitations in the methodology of the study. However, there were some interesting features that came out about potentially proactive levels being the way to go. This is probably where I use it the most, is in your sick ulcerative colitic patient that you're starting on infliximab or adalimumab after the induction course, so that 10-week to 14-week, using that level to make a decision. Do you escalate therapy or do you shorten the interval? And interestingly, what this study showed is by proactively doing a post-induction level, you actually could improve outcomes. So if you were to take home one point about when to potentially do proactive testing, it would be in your post-induction, and remember, this is infliximab and adalimumab, your post-induction measurement. So the therapeutic drug monitoring conclusions, and how do you put this into practice? Well, I think most of us would agree that reactive testing, and by the show of hands in the room, you're doing this already. Somebody loses response and you check a level. More cost effective, it appropriately guides therapy, and if somebody has very high antibodies, persisting with that agent does not make sense. Proactive in a maintenance standpoint, if you want to optimize monotherapy, this is another area where possibly if you de-escalate off of Imuran 6-MP methotrexate, or if you're a believer in not using combination, I would urge you that proactive testing is probably a better way to go in terms of making sure the levels are appropriate and to avoid the immunogenicity. I mentioned a minute ago stopping concomitant immunomodulators. I do think if you have somebody on good combination therapy and you're de-escalating, it would behoove you to do a de-escalation check of levels, and then usually I'll do it 2 to 3 doses, or 2 to 3 months later I'll check another when they're on monotherapy from de-escalation to ensure that they're not developing antibodies and dropping their levels. In terms of induction, I already mentioned a minute ago, for post-induction ulcerative colitis, I would throw in very severe Crohn's, maybe another area to look at this. And I think that there are still gaps in terms of the accuracy, the accessibility, the expense. Some of the biggest barriers that I hear in the community are this is just simply too expensive to send. There are benefits now in terms of the cost coming down, but this is still something we need to look at. So in the last 7 to 10 minutes, I'm going to actually try to put together what you heard this morning in terms of positioning the therapies we have. So it's often asked, which one do we use first? You heard on the panel discussion a little of this, but these are the currently approved treatments. In the next 2 to 3 years, we'll have several additional. So there is a stratification tool by the AGA, and if you haven't seen these are actually pathways now that insurance companies are using. You can actually do it as an app on your phone through the AGA. I put the little decision tool link up there, and there are many others. Now, unfortunately, these get outdated quite frequently, so we have to update these. Ulcerative colitis I would put into 2 flavors, 2 categories: low risk for colectomy, high risk for colectomy. And that would also translate into low risk for colectomy are probably the patients who do quite well with 5-aminosalicylates and do not need additional therapy. You see these in your practices all the time. These are not patients that we need to escalate, and they're doing quite well. The high risk for colectomy, you can read down, these are younger, more extensive colitis. We are seeing more of these patients, in my opinion, in the last decade. Deep ulcers, I think you've heard from every speaker. If you do a scope and you see deep ulcers, this is not a patient that you're going to use 5-ASA ever, in my opinion. If you use steroids, which is reasonable and practical, and I think Steve mentioned just from an insurance standpoint, getting whatever you want approved. But if you use steroids, you're moving to a biologic therapy pretty quickly. So this is the way the pathway looks. The induction, interestingly, uses initiation of steroids and thiopurines. This is where I think it's already a bit outdated. We're not doing steroids and thiopurines for ulcerative colitis. However, anti-TNFs, vedolizumab, I added tofacitinib would be the agents that we would consider for induction and then for maintenance. And at the very bottom left of the slide, and David presented the Unity data, ustekinumab will come. So we have basically 4 different classes of action for induction and then soon to be also for maintenance. You've already heard the Varsity study, adalimumab versus vedolizumab. David did a very nice job of going through this. I won't go through this in detail except to say that for all primary outcomes and all secondary outcomes except for steroid-free remission, vedolizumab outperformed adalimumab. And there were limitations, and as David said, we don't know the levels of drug. We don't know if we dose escalated adalimumab. This is my editorial comment now on this study. I think that adalimumab is a very good drug. I think it works. I think the problem is for much of IBD, it's underdosed. A fixed dose of 40 milligrams subcutaneous shot every 2 weeks is too low, and this is in my opinion. And there are obviously studies looking at higher doses in your practices. You see that if you escalate the dose, you can achieve remission. The problem is the label gives 40 every week as a maximal dose, and if you want to go higher than that, the insurance companies don't pay for it. So I think this study, if anything, brings out that this is probably underdosed adalimumab versus vedolizumab, which did outperform in all metrics. I want to spend a minute on the inpatient colitic, and I'm glad this came up this morning because this is probably what we struggle with the most and we're seeing more and more. All hospitalized patients, I put in bold letters at the bottom. We've talked about this. This is a take-home point from this conference if you haven't had this already. We must put these patients on low molecular weight heparin when they come to the hospital. The colitis itself is a risk factor for DVT and pulmonary embolism. Steroids, infliximab, and cyclosporin are the three players that we have right now for treatment in the hospital. Tofacitinib actually may. We need to wait for those data. There are some very high-dose tofacitinib studies ongoing. Maybe tofacitinib would be reasonable in the hospital as well. So this is my kind of overview. When a patient comes in admitted with severe colitis, if they have toxic megacolon out of the gate, or as Jean-Fred mentioned in that one case I presented, when they're really sick, get the surgeons involved day one. I'd rather have the surgeons meet them and them not go to surgery than meet them when they're rushing them to the OR for an emergency. Rule out infection. C. diff has become an epidemic. We are seeing increased CMV. We can have a discussion on what CMV means. But to me, CMV is a harbinger of just very bad colitis in most of these patients rather than a primary infection, but that can be another decision point. You see the blue bar in the middle, IV steroids 1 to 2 days. It is my firm belief that the days are gone of lingering on 7 days in the hospital failing IV steroids. We need to act much faster. So patients who hit the door, we're screening them if we want to give an anti-TNF for TB, for hepatitis B, and by day 2, we're looking to do something. The other pearl that I tell my fellows is I do unprepped exams on these patients. I do not give these patients a gallon of Go Lightly or any prep. They're auto-prepped. Use a pediatric colonoscope. If it's really bad, stop and call it a sigmoidoscope biopsy for CMV and come out. If it's going smoothly in the scope, you go without looping with a pediatric scope and you think the patient may need surgery, not bad to try to get to the ileum, but don't push too hard. But I use a pediatric scope. I do not prep these patients. If they're failing a day or two, then in Chicago, probably cyclosporin may be a reasonable next step. Infliximab probably for much of the country and probably higher dose 10 milligram per kilogram. I put tofacitinib with a question mark because I think that is probably to come. And don't look at surgery as a failure of treatment. Do you want to save the patient's colon or do you want to save the patient's life? And there are many times where we linger and persist too long and we should go to surgery more quickly. So again, we have to get a lot faster than we have in the past. Switching now to Crohn's, and then I'll end with kind of how I position these therapies. Crohn's is also 2 flavors, but not split evenly. Low risk for surgery or low risk for progressive destructive disease is probably only 20 to 25%, but probably many of you in this room see those patients more than us on the panel. So these mild Crohn's ileitis patients who maybe you see for mild symptoms, budesonide may be a reasonable treatment. We probably don't need to escalate. But 75% of Crohn's patients will present with more aggressive disease and need more therapy. Safety, we need to take this into account. You've seen my safety pyramid before. This is something Ben Click and I published in just earlier this year. This was kind of my old paradigm or old pyramid where I put veto at top, ustekinumab, and then you can go down to the bottom. I've modified this a little bit based on some of the safety data, acknowledging up front they're not prospective head-to-head comparisons for safety on all of these, but I have put parity around vedolizumab and ustekinumab in terms of safety. Vedolizumab, I think we all think in terms of the gut selectivity, is absolutely safe. But the data on ustekinumab and safety is looking very good. And then you can see from here. I still put tofa where I'm putting it now. However, I think as we gain more experience with tofacitinib, I might also bump that up the safety ladder a little bit higher. And then the worst agent is steroids, as we said. And the other thing to keep in mind from safety is inadequate treatment, not treating a patient fully, is an adverse event. So repeated steroids, 5 ASAs in patients who aren't doing well. Why is undertreating an adverse event? Well, I list the flare, hospitalization, colectomy. Cancer, obviously smoldering colitis for years, cancers, we still are seeing these patients. And then cardiovascular disease and clots. And again, we've, I think, beaten that to death in terms of the clot burden and risk in these sick patients. So these are my positioning slides. This is how I look at it, and then I'll give you one conclusion slide to summarize, and then I'll end there. So for ulcerative colitis, we have the TNFs, the JAK inhibitors, and the anti-integrins. So TNFs, they come in two ways, IV or sub-Q. Rapid onset, I think most of us are using infliximab, maybe even higher dose in the hospital. If, by the way, you give 2 doses of infliximab within 5 days of a patient who's hospitalized and they're not responding, they need surgery. I don't go to TOFA, I don't go to cyclosporin, they need surgery. So that's one thing that I will be very clear when a patient comes in and I tell them that. Probably the data show anti-TNFs are best with immunomodulators, the success trial in UC. However, we have to weigh the anti-TNFs with a risk of infection, with a risk on their own of lymphoma, especially though with thiopurines. How about the JAK inhibitors? Well, all, at least Americans, love oral therapy. So this is a pill, easy to take twice a day. Rapid onset, monotherapy, no immunogenicity. Maintenance, well, maybe we can use a lower dose. Maybe you can start and stop the JAK inhibitor as well. That's one thing that we may have mentioned this morning, but this is not something that if you're on and stop it, you can't restart. So if you do have to interrupt therapy, you can start it again. We are looking at the infectious risk. Zoster's real, but with Shingrix now, and we had a discussion about that. Pulmonary embolus, again, in RA, not yet in UC, but we know UC itself is hypercoagulable. The integrins IV, although subcutaneous vedolizumab is probably going to be first quarter 2020, so you will see the subcutaneous every 4 weeks is the prediction. Onset is also fast with low immunogenicity, and we use it as monotherapy. And then Varsity, we know that at least based on the data, vedolizumab outperformed adalimumab, and it has long-term safety benefit. Crohn's, TNF anti-integrins, the differences, you pick up ustekinumab here and you lose tofacitinib. So the anti-TNFs are pretty much the same as I mentioned for UC. The integrins are essentially the same as well, that these seem to be safe. One caveat, vedolizumab in Crohn's disease patients absolutely works better if that is the first agent used, not after an anti-TNF. We do see an attenuation of response. How about the integrins? Well, one single IV dose followed by sub-Q. Most of our patients like that dosing strategy. It works fast. Interestingly, it does seem to work after patients who've been on an anti-TNF. So the data at least have shown this. Excellent safety profile, low immunogenicity, and we mentioned for psoriasis that this is something as well. So this is my practice, and I should make the editorial comment. This is how I practice based on the data. And then again, the insurance companies, for better or for worse, will often dictate the first treatment. Any age patient with severe inpatient ulcerative colitis today, may change tomorrow, in my practice I'm using infliximab 10 milligram per kilogram. If they respond, I am adding either azathioprine or methotrexate. Tofacitinib may be a reasonable option to come, and cyclosporin certainly in those that use it, but just to be transparent, I'm not using cyclosporin. If there's a loss of response to an anti-TNF, I think it depends if it's an IV infliximab or sub-Q first, what you do second. So by what I mean is, if you have a loss of response to a subcutaneous anti-TNF, I will go to an IV infliximab. However, if you lose response to IV infliximab, I will move out of class. And I think that just has to do with the ability to dose the anti-TNF appropriately. That's what I do in my practice. If they're primary loss of response, then obviously switch out of class depending on the disease. Ulcerative colitis over 60 or under 60, again depending on the insurance, vedolizumab has become my first-line treatment if it's more of a moderate outpatient case. tofacitinib for more severe patients, infliximab for more severe patients. And then the question is, where will we position ustekinumab in all of this as well, given its good safety profile, and as David mentioned, the histoendoscopic improvement. Crohn's disease with one segment of bowel, ileal disease, no fistula, not extensive. I think it's still reasonable to consider in that group veto or ustekinumab as first line. And we can probably as a panel discuss which we use first, but I would say veto and ustekinumab. I will tell you the insurance companies are leaning more veto when we push for first line over ustekinumab, but I think both of those are very reasonable. Extraintestinal manifestations, if it's secondary to bowel inflammation, any are fine. If, however, it's pyoderma, uveitis, central arthritis, I would still use an anti-TNF as my first agent of choice for those severe extraintestinal manifestations, and then ustekinumab maybe in some of the Crohn's patients. And then finally, pregnancy, methotrexate, I stopped. Absolutely stop. Want the young woman off of methotrexate for at least 3 months. Tofacitinib for now, I would say the same thing. However, there may be data emerging that we can use tofa in second and third trimester pregnancy. I would not recommend that to anybody in the room today, but stay tuned. And we do stop tofacitinib before pregnancy. And then finally, we just have to adapt to all the new therapies, kind of like my city and football team of choice. So thank you very much for your attention, and I look forward to the panel discussion.